అలా క్లోజ్ చేయకూడదు
సార్.
ముందు లాగౌట్ అయ్యి షేర్ స్క్రీన్ స్టాప్ చేసి ముందు దాని మీద ఫుల్ స్క్రీన్ ఫస్ట్ నువ్వు పెట్టేసుకొని తర్వాత ఈ కింద బార్డర్ లో కొట్టుకొని మళ్ళీ అక్కడ కొడితే వస్తుంది. నిన్న అలా చేసాం
సార్. యాక్చువల్లీ ఇప్పుడు కూడా అలాగే ట్రై చేస్తాను సార్. ఇంకోసారి ట్రై చేస్తాను.
ఫుల్ స్క్రీన్ పెట్టి
అలా
కింద నుంచి షేర్ కొట్టాలి ఆ స్క్రీన్.
కొంచెం లేటుగా
సార్ అలా అవ్వట్లేదు సార్. ఎందుకు ఇందులో మేబీ ప్రాబ్లం ఉంది అనుకుంటా సార్.
లేకపోతే శ్రీకాంత్ పంపించు స్లైడ్స్.
శ్రీకాంత్ పంపించాను సార్. హలో శ్రీకాంత్.
అదే ఇక్కడ సిస్టమ్ నుంచి లాగిన్ అవుతున్నాను. ఒక్క నిమిషం.
ఓకే.
కాదు కిరణ్, నువ్వు స్టాప్ షేర్ కొట్టవా? నేను ఐ విల్ షేర్ ది స్క్రీన్.
స్టాప్ చేస్తాను.
Visible sir, full screen.
ఫుల్ స్క్రీన్ లేదు శ్రీకాంత్.
ఇక్కడ ఫుల్ స్క్రీన్ వస్తుంది సార్ నాకు. సేమ్ టెక్నికల్ ప్రాబ్లం. కిరణ్ ఎప్పుడు
శ్రీకాంత్ ఇప్పుడు కూడా ముందులానే వస్తుంది, ఆఫ్ స్క్రీనే వస్తుంది, గుర్తుగా
Okay.
రావట్లేదు. ఇలా ప్రొసీడ్ అయిపోతామా?
యా స్లైడ్స్ స్టార్ట్ అవుతున్నాయా, స్లైడ్స్ మూవ్ అవుతున్నాయా?
స్లైడ్స్ మూవ్ అవుతాయి, స్లైడ్స్ మూవ్.
Okay. Okay, so sorry for the technical issue. Good morning, everyone. So today we'll be discussing a nice topic, titled "Tug of War at the End of Anesthesia." So Dr. Kiran, HOD from GMR Care, will be talking about our stuck ET tubes, epidural catheters, and so okay. Already we are running late. Okay, Kiran, start.
Morning, sir, and good morning, Mohan Rao, sir. Today I selected this topic called Tug of War at the End of Anesthesia. It is a rare topic, but I want to present a different topic. That's why I chose this topic. Generally, during the anesthesia, we attach so many monitors, we attach so many wires, we use so many tubes, we use so many wires to produce safe anesthesia of the patient. But at the end of surgery, due to various reasons, we may not able to remove all the wires and tubes that we placed into the patient. Today I am going to discuss about two different topics. That is, one was entrapped epidural catheter and second one is the entrapped epidural tube. So epidural is one of the most commonly practiced analgesia technique and anesthesia technique, and it can be combined with the general anesthesia for laparotomies or any thoracic surgeries, and it is one of the more common form of labral analgesia, and it is most commonly used for the post-operative pain relief also. But we commonly use a epidural catheter. It can become kinked in the epidural space. It may knotted in the epidural space. It can get migrated up and down or into subarachnoid space. It may get breaked. It may be entangled to the various structures that present in the epidural space. This causes the entrapment of the epidural catheter. Next. Anesthesiologists very rarely face difficulties in the removal of the catheter owing to the various factors. A catheter can be entrapped inside the epidural space due to entanglement, or it can be due to knotting. Next. After administration of epidural catheter, why we have to remove epidural catheter, we all know, because it causes a foreign body irritation or inflammation or source of infection. And when we should remove epidural catheter also, we are aware. And the most important thing is what we have to see while removal of the epidural catheter. One most important thing is tip of the epidural catheter, the blue tip or green tip, which is intact or not. If it is intact, means we remove the epidural catheter completely. If it is not intact, means some part of the epidural catheter is missing in the epidural space or some other space in the patient body. Is the patient complaining with pain while we removing the catheter, means this epidural catheter is entangled to the any nerve root that present in the epidural space. So we have to stop further pulling of the epidural catheter. And another one is we're not able to, there will be no pain while removing the catheter, but we're not able to pull the epidural catheter freely, means it is due to entanglement of the catheter. So various structures present in the epidural space. Next. There are various reasons for the entrapment of the epidural catheter. It can be from our side due to the technical problems. It can be from the patient side. It can be from the catheter related factors. Coming to the technical factors. Next slide. So whenever we are want to keep epidural to any patient, we have to, first of all, we have to check the epidural kit physically for any entanglement, for any damage that present already in the epidural kit. First, we have to see that. Second one, which position we are administering the epidural catheter. Generally, sitting position, generally we all practice sitting position epidural placement. Sitting position placement of epidural catheter will carry more chances of entanglement of the catheter when compared to the lateral, because in sitting position we need a greater force of pushing the catheter after identification of the epidural space. Coming to the which approach we are using while identifying the epidural space. Midline approach is having more chances of entanglement of the catheter in the epidural space than the paramedian approach. Coming to the other technique, how to identify the epidural space, it is loss of resistance to air or it is loss of resistance to saline. Loss of resistance to saline will have lesser chance of entanglement when compared to the loss of resistance to air, as it creates an active space inside the epidural cavity. Next one is whether we are facing any difficulty after identification of epidural space while inserting the catheter. If you facing a difficulty while inserting the catheter, means there will be a chance of occurrence of entanglement is there. So you should be very careful. And one more other thing is, after identification of epidural catheter, we pass the epidural catheter into the epidural needle. After 10 centimeters of the length, we are finding a difficulty in further advancement. Then we have to remove the catheter back and we have to readjust, and again we have to reinsert the catheter. We should not turn the needle and insert the catheter. If we are turning the needle with a catheter inside, then it will cause an entanglement. Coming to the length of the catheter that we keep in the epidural space. If you keep more length of the catheter in the epidural space, there will be more chance of entanglement. So generally there is a rule of 5 centimeters. We should not keep a length of more than 5 centimeters in the epidural space. Generally now they are falling 2 to 3 centimeters in the epidural space. And one more important thing is which position we are removing the epidural catheter. Lateral position is the best position for the removal of the epidural catheter when compared to the sitting position. And one more thing is duration of the epidural catheter that is present in the epidural space. Generally, we will remove epidural catheter in 48 to 72 hours. If forgottenly patient got discharged or due to any other factors, if we forgot the removal of the epidural catheter below after 2 weeks, then there will be every chance that there is an entanglement of the epidural catheter in the epidural space. Then you should be very cautious while removing the epidural catheter. Coming to the second part, coming to the patient factor. Middle-aged females are the more commonly associated with the entanglement of the epidural catheter. As per the studies, we don't know exact the reason. There are due to labor analysis, I think. So middle-aged females are more vulnerable for the entanglement of the epidural catheter. And patient cooperation is also important while doing the procedure. If the patient is not cooperating, he making the back very stiff, then you need a more force while inserting the epidural catheter, which causes a chance of entanglement to any other structure. Coming to the other factor, that is the next catheter related factor. Which type of catheter you are using, whether you are using a reinforced catheter or you are using a non-reinforced catheter. Reinforced catheters are resistant to kink. And what is the tensile strength of the catheter? What we are using? Less tensile strength catheters will be least stretched and it is easily broken in the epidural space. And which diameter of the catheter we are using? Bigger diameter catheters are safer when compared to smaller diameter catheter. These are the catheter related problems. Next. When you are suspecting the entrapment of the epidural catheter, don't get panic and don't pull the catheter further. And we have to investigate further what happened to the epidural catheter. Next slide. Coming to the different tests or diagnostic part of the entrapment epidural catheter. First one is the saline flush test. We flush the
Kiran, just 1 second. Mohan sir wants to share the screen and keep it full screen. Wants to try. Once I'm stopping the share, we will, you can just speak about the diagnostic test.
Okay. Regarding various tests that will help in the identification of the stuck epidural catheter in the epidural spaces. First and foremost is the saline flush test. We will push the saline in the epidural catheter. So if the saline is going freely, that means epidural catheter is intact and epidural catheter is not having a tight knot. If saline is not going freely, means epidural catheter is tightly knotted around some other structure. Other tests are X-ray. If epidural catheter is radio opaque, and you can inject a radio opaque dye in the epidural catheter, and you can see whether it is able to see the situation or the position of the epidural catheter, whether it is entangled, whether it is knotted. You can see. You can do ultrasound, you can do MRI, you can do CT. Sir, back, sir. Okay. Sir, little bit over. Patient. Next one, sir. Technique over. Next, patient factors is also over. After diagnosis, management part. Next, sir. Next. Coming to the management of the retained epidural catheter. It can be non-surgical conservative approach, or it can be non-aggressive approach, or it can be surgical approach. When epidural catheter is broken, or if it is entangled to nerve, that indirectly we can see that when we are pulling the epidural catheter, if the patient complains of the pain, radiculating pain, so that means it is entangled to nerve. So you are not supposed to go by non-surgical approach. You have to go by surgically only. And if epidural catheter is broken inside the epidural space, as it may cause irritation, or it may cause source of infection, so we have to go by surgical approach. Coming to non-surgical approach that we commonly practice, sir. So next slide, sir. Coming to non-surgical approach, when there is no contraindication for blind removal, you can go for the non-surgical approach. That means if the epidural catheter is not entangled to any nerve, or there is no coagulopathy, you can go for the non-surgical treatment. Do a saline flush test, as I already told. You have to apply only the gentle and constant traction to the epidural catheter, and you should not use a force. If you apply vigorous force, the epidural catheter will get stretched and it will get broken. First, try in the lateral position, which is the best position for the removal of the stuck epidural catheter. If lateral position is not successful, then keep the patient in the same position, the position in which we administered epidural catheter into the patient's epidural space. So whether it is lateral, you keep him in lateral. If it is sitting, make him into the sitting position and try to pull the catheter gently. So when you are keeping the patient in the same position, so you try to flex and extend the spine so that epidural catheter may come out with a gentle pressure. Next slide, sir. If catheter is stretching, so previous slide, sir. If catheter is stretching while removing, so you have to leave the catheter like that for some time and try again. If still not successful, tie a small weight like tongue depressor or knee hammer and hang it freely from the patient body to down for 15 minutes and wait for its spontaneous removal. Or if it is not successful, repeat the procedure again once or twice or go for surgical management. Some tried passing the epidural needle over the epidural catheter and try to go into the epidural space and remove en bloc the epidural needle along with the catheter. But nowadays, nobody recommending that, as we are passing the epidural needle over the struck epidural catheter, as it may going to break the epidural catheter inside the epidural space. If it is not successful or if it is broken already, go surgically after explaining the patient regarding the further process. Next, sir. Coming to the second one, surgery part, when the epidural catheter is entangled to the nerve root, or if we are not able to remove the catheter by conservative approach, then we have to go by surgical intervention. To go to the surgical intervention, first we have to identify where the epidural catheter, so that we have to, in the anesthesia notes also, we have to write where the epidural catheter, in which position we are administered epidural catheter, everything. Based upon that, you can go which level we are going to give incision, or you can further you can take radiological assistance about the position of the epidural catheter and give the incision and try to remove the epidural catheter from the epidural space or any other area where the epidural catheter is got stuck. Or if it is smaller epidural tip is remained in the patient body, whether it is in the epidural space, so you can wait and watch also. If there is problem appears due to the epidural and retained epidural catheter, then you can export the patient surgically and remove. It is depends on the patient and surgeon aspect. Coming to next. Next slide. Coming to the second common thing is entrapped endotracheal tube. Next slide, sir. Intubation and extubation are common practice of anesthesiologists, but we may come across the entrapped or stuck endotracheal tube inside the patient's airway, which is not coming out with a gentle pull. Even though it is very rare, it is almost 1 in 10,000 cases. If we're not dealing it very properly, it will cause a serious complications like airway injury, erythenoid injury, glottic injury, everything. So it will, as it is problem with the airway, it is very dangerous situation. So we have to know everything about the entrapped endotracheal tube. It can be due to 3 reasons. It can be due to faulty technique from our side. It can be faulty endotracheal tube. It can be due to various surgical factors from our surgeon side. First, coming to the faulty technique. Next slide, sir. So first and foremost thing is when we are selecting when we are preparing for intubation, you have to select a proper endotracheal tube. We should not select a bigger endotracheal tube size, so it will cause more damage to the patient's airway, and it will prevent the extubation due to physical factors. So second one, improper checking of the endotracheal tube prior intubation. We have to check the position of the functional status of the pilot balloon, functional status of the pilot tube, and functional status of the endotracheal tube cuff, whether it is inflating, whether it is deflating, whether valve function is normal, whether there is any kink in the tube that connects the pilot balloon to the cuff or not. We have to check physically. Without that, if you intubate, you may come across this problem. So majority of the people, they practice application of lignocaine gel to the endotracheal tube cuff. So it will help in the removal of the catheter at the end by not attaching to the tracheal mucosa. Prevent the attachment of the endotracheal tube cuff from the attachment to the tracheal mucosa. And one more important thing is traumatic intubation. So when we are not assessing the airway properly, when we are having encountered a difficult airway, then if we take multiple attempts while intubating, so there can be chance of laryngeal edema. It can cause a entrapped endotracheal tube. And one more important thing is improper muscle relaxation during the entire course of the surgery, that allowing the tube bite during the surgery. So biting the tube, we can monitor by the fall in the ETCO2, fall in the saturation, increase in the peak pressures and everything. If the bite happens on the tube that connected the pilot balloon to the endotracheal tube cuff, we are not able to monitor all these things. So at the end of the procedure only, we will come to know that there is a damage to the pilot tube. So if the pilot tube is got damaged by the biting of the patient due to improper muscle relaxation, we may not able to extract, or we may be able to remove the air that present in the endotracheal tube cuff, which may further impede the removal of the endotracheal tube. And one more important thing is improper bite block placement and improper taping. When we are taping also, if the connecting pipe between the pilot balloon and endotracheal tube cuff, if it is kinked, there can be chance of entrapment also. And over deflation of the endotracheal tube at the end of extubation. When we are extubating, we will try to deflate the pilot balloon so that endotracheal tube is deflated. When we are removing the excess of air than what we kept inside, there will be, when endotracheal tube cuff is got deflated, it will entrap the some of the tracheal mucosa in it, so that it will prevent the removal of the endotracheal tube. So we should not over deflate the endotracheal tube cuff. Next slide. Another point is we have to demonstrate the cuff leak test prior each and every extubation, whether it is in the operation theater, whether it is in the ICU, especially in the ICU due to prolonged ventilation. And one more important thing and uncommon thing is when we are using some other catheters, whether it is monitoring catheters or it is nasogastric tube or orogastric tube or nasopharyngeal temperature probes or esophageal temperature probes, along if the patient is already intubated, so there can be chances that entanglement of this tube over the endotracheal tube, which further which cause a problem while removing the endotracheal tube. So we have to see that one also. Next one. Coming to endotracheal tube factors that is causing its own entrapment. If pilot balloon problems, whether the valve is functioning or not. Second one is inflating tube, whether it is damaged. If there is any cuff problems, we have to see cuff is not inflating properly or deflating properly. Then also, if it is not deflated properly, then it will have problem while extubation. It can damage the glottic structures and erythroids. Next one, sir. Coming to pilot balloon problems. Pilot balloon problem, it is the most important thing is that pilot balloon pressure, that what we commonly check in the ICUs or in those patients where we are having prolonged ventilation, pilot balloon pressure does not always reflect the pressure of the endotracheal tube cuff. So deflated pilot balloon does not mean that endotracheal tube cuff is already deflated. In other words, pressure that what we measure at the pilot balloon may not always reflect the pressure at the endotracheal tube cuff. Because if the tube that connecting the pilot balloon and endotracheal tube cuff is kinked or damaged, pilot balloon may get deflated, but there can be chance that endotracheal tube cuff is still inflated. We don't know. So this is one of the important thing. Next, sir. There can be different scenarios. Pilot balloon may be deflated, but endotracheal tube cuff is deflated. And another scenario is both pilot balloon and cuff are not deflating. Both pilot balloon and cuff are also deflated. Next, sir. Coming to pilot line, that is pilot balloon to inflating tube, it can be kinked or crushed due to bite or due to improper taping. It can also happen. We have to check this one also prior extubation, or if you have a problem while extubating. Next, sir. Coming to endotracheal tube cuff status, if it is not deflating due to various reasons, as we already mentioned, or if it is only partially deflated, or it is over deflated. If it is over deflated, it will attach the tracheal mucosa and prevent the further removal of the endotracheal tube. Next, sir. Coming to surgical factors from the opposite side. So if during any anterior neck surgeries, if there is accidental knotting of the endotracheal tube happens, it will also cause a entanglement or entrapment of the endotracheal tube. So it prevent the removal of the endotracheal tube. Some surgeries like tonsillectomy, cleft palate surgeries, they will apply some retractors. So those retractors will apply pressure not only on the endotracheal tube, so that now what we are using is reinforced tube to prevent the pressure on the endotracheal tube. But these retractors may damage the tube that connecting the pilot balloon and endotracheal tube cuff. If it is got damaged, so this problem will arise. Some surgeries like tracheoesophageal surgeries and anteneck surgeries may be associated with accidental knotting of endotracheal tube. And if there is any laryngeal edema, there can be chance of the entrapment of the endotracheal tube. Next, sir. Then if tube is entrapped, what to do? Again, take the patient into the deeper planes of anesthesia and examine the patient airway and examine the endotracheal tube. Next, sir. Do cuff leak test before extubation in every patient, and we have to check the status of the pilot balloon and its tube and endotracheal tube cuff if you are facing this problem. Next, sir. Coming to diagnosis based upon the physical inspection of the palate balloon, inflating tube, and the cuff status. You can do a direct laryngoscopy to see whether there is any laryngeal edema or any damage to the endotracheal tube cuff or anything. Inspect the glottic thing. You can pass a fiber optic into the endotracheal tube. You can see the status of the cuff or any entanglement of the other catheters or any knot from the surgical site is present or not. Or you can do a CT scan. Next, sir. Coming to management, shift back the patient into the deeper planes of anesthesia and maintain the vitals properly, and call for help, and identify the preliminary cause and based upon the physical, radiological, fiber optic evidence, and count the surgical factors also for this cause. Next, sir. Do a cuff leak test. This is the first and foremost thing. If cuff leak is present, the endotracheal tube is not coming out, means it is somewhere due to surgical knots or due to entanglement. So tube is not coming out. So then you have to reinflate the endotracheal tube cuff and remove all the causes, like if tube is entangled around the endotracheal tube with McGill's force, if you try to remove, or you can remove both the tubes together if they are passed into the same cavity, like if they both are present in the oral cavity, in the oral approach, then you can remove both the tubes together. If due to surgical knot, you have to discuss with the surgeon and reopen and remove the suture. Next, sir. If cuff leak test is negative, don't expect the patient. Look for any glottic edema secondary to the surgery or due to intubation injury or due to airway manipulation. If edema present, wait for extubation and reinflate the cuff and wait and treat the glottic edema. If the patient is developed glottic edema, you have to wait and watch, treat the glottic edema, different causes of the glottic edema, and once the cuff leak test is positive, then only you have to extubate. If there is no glottic edema and cuff leak test is negative, means we over deflated the cuff. It means you have to reinflate the endotracheal cuff with 1 ml of air, 1 or 2 ml of air, and try to extubate gently. Next, sir. Malfunction of the tube, pilot balloon, and endotracheal tube cuff system. So next, sir. This is a table form that represents all the things. So here we are mentioning about the pilot balloon status, endotracheal tube cuff that present inside our airway, and what is the reason for this situation, what are the treatment options. If coming to first scenario, if pilot balloon is inflated, it is at the end of procedure, we try to deflate the pilot balloon so that we are thinking that we are deflating the endotracheal tube cuff. This is an unusual scenario where when we are deflating the pilot balloon is not getting deflated. So we're not able to extubate the patient as endotracheal tube cuff is already inflated, as we are not able to deflate. The reason is that there will be fault in the balloon valve. So you can then, how to manage this patient means you have to cut the inflating tube or puncture the endotracheal tube transverally through ultrasound guidance so that you can remove the endotracheal tube safely. It is unusual situation. Coming to second scenario where pilot balloon is deflated and endotracheal tube cuff is also deflated, but endotracheal tube is not coming out. The reasons are, it can be due to overinflation. If it is due to overinflation, then you can reinflate with 1 or 2 ml of air and try to remove gently. Or if it is due to, or it can be due to entrapment due to other tubes or due to surgical knots, or it can be due to laryngeal edema. Then treat the laryngeal edema. Then if the cuff leak test is again positive, then only extubate the patient. Coming to third scenario, which is most usual on these unusual scenarios, where pilot balloon is deflated completely, but endotracheal tube cuff is not deflating. Either it is completely not deflating or partially deflating. So it can be occur due to kinking of the inflating tube or damage to the inflating tube. Then you can cut that pilot balloon tube distally or towards the endotracheal tube cuff or you can puncture the endotracheal tube cup by ultrasound guidance or by direct laryngoscopy. So coming to fourth scenario, where pilot balloon is inflated, but endotracheal tube cuff is deflated. It can be due to faulty valve with endotracheal tube cuff damage. Extubate if required. If the patient, you are expecting a aspiration, then you can re-intubate the patient with a new endotracheal tube. Next, sir. Next, sir. Next. Thank you, sir. Thank you for patient listening of this rare topic. Thank you.
Thank you, Kiran. I think a lot of people are ready to discuss on this aspect. Did anybody get these two problems? Because with permission of Srikanth, can I ask a few questions to Srikanth?
Sir, sure, sir.
Epidural catheter, if it's been gone, do we keep it, leave it, or do we do anything?
Epidural catheter gone means it is.
While
got
removing
left
it,
inside
it's been
epidural
not
space.
able to come, it's gone.
Sir, if epidural catheter is break that is placed in the epidural space, if it is not causing any problem, you can wait and watch after discussing with the patient. If it is not causing any neurological problem, or if the patient is having any neurological problem, or if the patient is developed any infection in the epidural space, suspecting any infection, then you can remove the epidural catheter surgically.
So previously, can we do any contrast study or remove do we require to have that much intervention to remove the epidural catheter?
Yes, sir. To know the status of the epidural catheter that is placed, that is knotted or entrapped in the epidural space, you can, some epidural catheters are radio opaque, sir. You can see the status of the epidural catheter. It is knotted, or what is the situation of it in the epidural catheter, or you can pass a radio opaque dye from the epidural catheter, you can see the status.
Did anybody got stuck in ET tube by anybody, anytime?
But sometimes when we are removing the endotracheal tube, when we are extubating, we often see that endotracheal tube cuff is not deflated completely, sir. Sometimes.
Yeah, that's okay. Understood. Thank you, sir.
Thank you.
I think everybody can tell their experience and talk, Srikanth. Thank you, Srikanth.
Thank you, sir. ET actually tightening console sometimes we experience a subglottic stenosis or laryngeal edema and all, but complete unable to remove actually didn't encounter. But sometimes CVC guide wires also get stuck, and those we have experienced. Actually, a topic, this question has been asked to me in my MD practical exams. So, is there a chance for ETT getting completely stuck during any surgery? I told them thyroid surgery, accidentally a surgeon can knot on the ET tube and all. They also laughed about it, but there are some case reports, it seems, during thyroid surgery, suturing goes through the ET tube and it gets stuck. So that's what. Upadhyay, Madhusudan Upadhyay sir untaga external కింద వచ్చారు సార్ మాకు ఎగ్జామ్స్ లోని. సో
Bangalore
బెంగళూరు ఆయన కేస్ రిపోర్ట్ బేసిస్ గా క్వశ్చన్ అడిగారు సార్.
బెంగళూరు కాదు,
అదే సార్, కర్ణాటక మొత్తం బెంగళూరు. సివిసి క్యాథెటర్స్, స్ట్రక్ క్యాథెటర్స్ తో కొన్నిసార్లు కుస్తీ పట్టాను సార్. కొంచెం యాంగులేషన్ మార్చుకొని నీటిలోంచి తీసి అలాగా. బట్ ఎపిడ్యూరల్ క్యాథెటర్స్ breakage ఎప్పుడు ఎక్స్పీరియన్స్ చేయలేదు సార్. స్టక్ catheters sometimes due to epidural adhesions and all we have చిన్న రొటేషన్ చేసి, బట్ దోస్ టెక్నిక్స్ మెన్షన్ బై కిరణ్ కొంచెం ఇంట్రెస్టింగ్ గా ఉన్నాయి. సమ్ వెయిట్ పెట్టి హ్యాంగ్ చేయడం అవన్నీ. We can try if we encounter the problem in future.
Good morning. I had an experience of sharing of the epidural catheter while removing. Immediately after surgery, ortho surgery for the lower limb, we placed epidural catheter, and at the end of the surgery, we tried to remove, and epidural catheter at the level of 8 to 10 centimeter, it was shared. Then fluoroscopically, surgeon detected that the catheter was inside the body, and counseled the patient the chances of migrating of the catheter and root compression, and patient agreed, and laminectomy was done and the catheter was removed. If a Foley's catheter is stuck, what will you do, Kiran?
Sir, actually, I want to tell about the Foley's catheter and CVC guideways also, but it will become more lengthy. That's why I restricted to epidural catheter and endotracheal tube. Sir, if Foley's catheter is got stuck, it can be problem at the wall, or it can be problem in the tube that is passing from the wall to the Foley's bulb, or it can be problem with the bulb. So generally, we inflate the Foley's catheter with the distilled water, sir. If unexperienced staff, or if they got inflated with the normal saline, it will get crystallized in the tube. So it will prevent the removal of the distilled water that present in the Foley's catheter bulb. So we're not able to remove the Foley's catheter. Then you have to pass a guide wire from the Foley's valve, that where we are injecting the distilled water. You can pass like CVC guide wire, you can pass inside, or you can cut the valve. You can see whether the water is coming out or not. If it is not successful, you can puncture by ultrasound.
Also, you can cut at the junction. If you cut,
yes,
sometimes
sir, at the junction we will cut, and we can see a smaller tube, smaller passage. We can pass a guide wire in that. If any crystallization that present in that smaller way, it will get displaced, so that it can get deflated automatically.
So it is always better to do cufflink test before extubating.
Yes, sir.
But books says that cufflink test is usually done for prolonged intubated patient, like in ICU.
Not only for the prolonged intubation patients, sir. If you are suspecting a laryngeal edema, if you are manipulating the airway, if you anticipated, if you encountered a difficult intubation, if you took a multiple attempts while intubating, then ideally you can do a cufflink test. It's generally suggested for the prolonged ventilated patients, but when these situations are also present, you can do a cufflink test. And especially when the tube is entangled, you have to do cufflink test.
Thank you.
Thank you, sir.
Any other questions or experiences? Okay.
రమణ ప్రసాద్ చెప్పినట్లు యాక్చువల్ గా లామినెక్టమీ అవసరం లేదు. బ్రాంకోస్ ఎండోస్కోపీ మన పెయిన్ క్లినిక్ లో ఎపిడ్యూరల్ స్పేస్ లో ఎండోస్కోపీ పెట్టి తీసేయచ్చు కదా.
ఇప్పుడు
అంటే ఆల్మోస్ట్ 2004 లో కూడా ఒకసారి అలా జరిగింది. 2004 కాదు, నేను అసలు యాక్చువల్గా పెట్టినప్పుడు వదిలేశాను, 1996లో వదిలేశాను. తీయలేదు, అసలు మర్చిపోయాం అది, అంటే పేషెంట్కి ఏం ప్రాబ్లం లేదని. బట్ తర్వాత 2004లో అక్కడ ఆస్ట్రేలియాలో ఉన్నప్పుడు వాళ్ళు ఎండోస్కోప్లో తీశారు. తర్వాత ఎండోస్కోప్లో తీయడం అలవాటు అయిపోయింది. బికాస్ మై ఓన్ ఎక్స్పీరియన్స్, ఐ ఫర్గాట్ గైడ్ వైర్ ఇన్ సెంటర్ లైన్ and actually lost epidural tip has been lost in the epidural catheter, and there was one patient sitting spinal post arrested. So everything, one patient, so many things I don't know whether it's my mistake or not, but I have experienced so many complications. Maybe because of my inefficiency at the time, I don't know what it is.
Sir, when we do more procedures, we will see more complications.
Volume.
అలా చెప్పుకుంటే గొప్ప అనుకుంటారు బాబు. ఉన్నది ఉన్నట్టు చెప్పుకోవడం బెటర్ కదా.
లేదు, ఎక్కువ ప్రొసీజర్ చేసేటప్పుడు కాంప్లికేషన్స్ ఎక్కువ అనుకుంటారు సార్.
అలా కాదు కదా, ఎక్కువ ప్రొసీజర్స్ అది కూడా తప్పే కదా. కావాలంటే అక్కడ రాణి మేడం లైన్ లో ఉందేమో, యూకేలో 8 hours కంటే ఎక్కువ పని చేయకూడదు అంటారు కదా. సో అలాంటప్పుడు మళ్ళీ అది కూడా ప్రాబ్లం ఉంటుంది కదా. సో ఎక్కువ టైం పని చేసేది కాబట్టి వచ్చింది అంటారు కదా. ఇప్పుడు అనురాధ ఎక్కువ కేసులు చేస్తుందని చెప్పి 30 days ఆన్ కాల్ ఉంటుంది, కార్డియాక్ లో కాంప్లికేషన్ వచ్చిందంటే ఒప్పుకుంటారండి కార్డియాక్ సర్జన్.
Sir, complications వస్తాయి సార్. How we are dealing is important in our scenario, sir.
I think one important point what I understand myself is, like for example, previously when I used to read pharmacology, only nausea vomiting is a complication. So like that, the complications, treating complications, understanding for anything is first to be learned before we go. So the seriousness will come, because most of the times when you are learning, MBBS people, critical care technicians, doctors and everybody, I want to do, that will come. So that's the reason normally when DME students want to do something, I tell please present that case, how to put an arterial line, how to put a center line. When they read it, when they present it, they'll understand the complications. And first I'll ask the complications, how to handle the complications. Then it's easy to, whatever you do also, yes, it's okay. That's what I feel. It's my perception, Dr. Kiran.
Yes, sir. During learning period also, if any complication happens in any operation theater, then all residents are all who are learning.
Why I'm seriously discussing with you, Kiran, because you are a DNB teacher, sir, and you are doing more than 500 cases per month there. And most of the times, the students, wherever we are learned, like yesterday, Anuradha put the message, wherever we learn and we put into that, and we will never unlearn that. So that is the reason that when you are learning itself, proper learning is very, very crucial. At the time when I was learning, it was so many mistakes were there, including the technique of not only putting infection control also. I mean, antiseptic pressures, somebody put like a dosa, somebody put like a square, somebody. So many things, including the suture material, including the position. Like for example, my colleague Chandra says, no, I can do anything blindly. See the overconfidence, and as well as not using any equipment is something great of intubation. Adjuncts is not should be used. So these kind of myths were there when we were students. I can do anything. Those kind of confidence will come after doing some procedures. So always, never ever feel. Now anyway that extended stethoscope has come. All our next generation, we are old generation. Next generation people are using all ultrasound machines for everything, which you are seeing through visibly, like spinal, epidural, everything you are doing through ultrasound, pain procedures, including intubation, putting a cuff pressures, looking at the cuff in ultrasound, looking at the confirmation not by ETC but by ultrasound. So much advancement has come, like like everything. So I think we should adopt to that. We should train to that. We should so that all these things only to prevent the complications, to improve the quality. What I understand. So anyway, it's really nice, and thank you. Sorry, I've taken a long time.
So good morning to all. Thank you, Kiran, for nice talk. Hello.
Thank you, madam.
So I have some experience. One is ET tube. So that is lung case. So during suction also, suction catheter is passing, but some secretions are coming. But unable to ventilate properly, very tight going. So let's say, so I send ABG, that ABG also PCO2 is rising. So almost luckily that surgery is ending time. So I thought to remove the ET tube and change the another ET. So I told to surgeon, I want to put the another ET tube. So I remove the ET tube and change the another one. So that ET tube center hole area and patient end and Murphy's end also total both areas is totally blocked with expectoration. So after that, PCO to reduce and everything, that is settled one thing. And second one is tracheal, some lung injury is there. So we plan to surgery. Actually, first plan is double human tube. I told it is difficult to pass the tube and sitting position. So I later we can plan. Now I'll pass only normal endotracheal tube. So I passed the endotracheal tube and surgeon opened. That is a bronchial tear. So I'm unable to ventilate. Totally ETCO2 straight line. So I told to surgeon I'm unable to pass the ET tube. Please, ventilate. Please see any leak is there. So surgeon is removed the clot immediately. That is bronchial tear. Luckily, we have bronchial blocker. So that is sterile one. So surgeon passed. I only passed in through the ET tube and a bronchial blocker is came. So immediately, Dr. Karnakar sir, I saw the blocker, so I blocked that one. So immediately left side I can able to ventilate. So luckily, that is a missed event. And later that patient shifted to isolation room. We are unable to extubate. So we thought we want to see the bronchoscopy. So surgeons saw the bronchoscopy, Karnakar sir and Nursing sir. So one flap is moving. So in a tracheal area, one flap is moving that took going towards the left side. Already right side bronchial tear is there, surgery over. And the left side, one flap is going towards the left side. So in first event, I'm unable to, that time a bronchial blocker I passed. So I told to I'm unable to pass that double human tube, single human. So if I pass double human tube, that layer gone to left side and block. So maybe that is introp event will occur. So luckily I missed that event and the second event also. Immediately postponed the extubation and planned for bronchoscopy properly. And Balraju came and removed the layer. After that, the next day only we planned to extubate. So that is the second event. I mean, that is my experience. And the third one is I have small doubt. You told about the epidural catheter is stuck in the area. So your contrast means you want to give the epidural area or you want to give the subarachnoid? Hello?
Hello,
Kiran, please.
madam. Actually, I want to give through the epidural catheter.
Epidural catheter struck that area. So you want to see the which place is there. So you want to, I mean, I want to go for contrast study. So in contrast, which area I want to give?
No, actually, I am saying that I will pass the dye in the epidural catheter that is coming out of the patient body. That's what attached to the hub. I will pass the dye through that epidural catheter tip.
Same
so that
space. Same space we want to give. If you
there
are giving
two
the
situations,
contrast.
Two situations, madam. If epidural
Okay.
catheter is already broken inside, it is not having any attachment outside, then you have to do a contrast study. Then you have to give contrast IV and you can see. Or if epidural catheter is got stuck, we are not able to pull the catheter out and everything is intact. Everything is intact, but it's not coming out. Then I will give a radiopaque dye through the epidural catheter, like what we give like local anesthetic. Then I will see whether what is the position of the epidural catheter that present inside the epidural space, whether it is having many knots or whether it is having any bends like that.
Actually, I have doubt already. Small part is there, epidural catheter inside only. So we want to remove that catheter tip, a small part. So you want to give the contrast means same area you want to give. So when you're giving the contrast, that catheter or small part will go upside or down any area, let the same place it will stuck. Any chances of
any chances of movement will be there. That's why only we will try to remove the stuck epidural catheter.
Okay, you are planning for so you want to remove the remove the catheter tip. So we are concerned given
broken if it is placed in the epidural space. If it is, we will discuss with the patient about the situation.
Okay.
If it is
Okay.
causing, there will be chance of migration, there will be chance of infection, there will be chance of
if migration is there, if you do plan for surgery, you are doing, so that time any same area you are seeing but are not able to see, so that time you want to see the C-arm or anything, you have to search that catheter part.
We have to do MRI or contrast CT to see what is the
MRI
location of
in the OT.
In the OT, it's not possible now. If it is radio opaque epidural catheter is there, you can see, but it is difficult with our routine mobile X-ray units. It is better to identify properly through MRI or CT.
In the C-arm, we're not able to see, na?
It is difficult. It is very
Difficult.
smaller size tube, and if it is not radio opaque, then we can't see also. If we are thinking that we kept the catheter at L3, L4, but if it is got breaken, it may be at L1, it may be at S1, we don't know. It will get migrated. So we have to identify where the catheter tip is there properly, then you have to do a surgery. If it is already broken, if it is intact, if it is not coming out, it is got stuck, then you can go along the track of the epidural catheter. You can go in the same way. If it is already broken, means it can go up, it can go down, or it can go into subarachnoid space also. So there will be entrapment of the epidural catheter. That's what we place. It will get migrated during the insertion itself to subarachnoid space, and it will get entangled to the nerve roots. It also can happen.
Okay. Next one more doubt. If ultrasound guided, you are doing epidural and spinals, no?
No,
so during ultrasound guided, that catheter able to see at least anything?
I don't know. I never practiced with ultrasound guided.
Okay. Shrikant, any idea?
Madam, అంత టాలెంట్ లేదు మేడం. అంటే అలాని కాదు. I mean, like most of the people, those who do also use ultrasound only for the identification of the spaces, madam. In difficult cases, the real time passing of epidural catheter, I don't think.
I have no idea. That's why I'm asking. And there's some people are telling under spinal also you can do ultrasound and you can go do. So
90% of the people, those are practicing also, and I mean like using ultrasound for spine also, they use mainly for the identification of the space and how much depth that epidural space is there and all. So to get that rough idea, I don't think anyone is doing real time passing of epidural catheter. If you're going to also, there will be much technical difficulty when placing the probe and also visualizing the needle in that small interlaminar spaces. I think it's difficult. Most of them that is just for identification of the space and the depth of epidural space from the skin, so that they can get a rough idea.
Okay. Thank you so much.
Thank you, ma'am. Okay, we'll wind up the class. Next week it will be DNB students. I'll speak to Shekhar regarding who is presenting.
No, Dr. Santosh is presenting.
Santosh madam. Okay, right. Thank you. Followed by GVP Medical College. Manjula madam will take care. Okay, thank you, Kiran. Nice topic and a very good. Thank you, Mohan sir, Ram Prasad sir, Anuradha madam.
Thank you, Mohan sir. Thank you, Anuradha madam, Ram Prasad sir.
Thank you, Kiran. Nice talk. Thank you to all.